So we're delighted to have with us Dr. Khalil Ghanem, who's an associate professor in the Johns Hopkins Medical Institutions based at Bayview. And he is going to talk to us about the public health response to HIV and syphilis. And so please join me in welcoming Khalil Ghanem.
Thanks so much. It's a pleasure to be here. Thank you for inviting me. And so what I'm going to talk about is sort of musings on what we can do to potentially try to control this epidemic. And they're merely musings, and hopefully it'll elicit some discussion in the next session. So I have no disclosures. And so we're going to talk about the problem and the challenges of trying to deal with this problem, essentially, as an overview. This is the problem. You heard about it from Adina, from Jackie, from everybody who talked, from Charlotte, everybody. So that's the problem. Here's the solution, right? And the solution, see, you thought it was going to be tough, but it's really not. So this is the solution. And we've essentially been following the recipe that Thomas Perrin came up with many decades ago. 1936 as Jonathan Zendelman. It was Jonathan Zendelman and Perrin worked together on this. Essentially, it has to do with screening, with treating, with finding the partners, with treating them, and public education. And there have been variations on the theme, but the theme is exactly the same. And the latest variation is from Tom Peterman's work that was just published in STD. It's a lovely paper. I recommend that you read it. And this is essentially reframing the 2018 version of the Perrin approach. So Perrin's approach has been used ever since the 1930s to try and control sexually transmitted infections. And if you could do all of those things, you would actually be able to control these infections. The problem is it's tough. It's not easy. And so I'm going to attack each one of those and tell you some of the challenges that exist there. Now, you might disagree with what I'm showing you, and that's okay. Remember, I'm presenting. And then, so essentially, the take-home is too bad. Live with it, and then come up and, heckle me. So here, let's start and deal with each one of these issues separately. First one is education. And I thought this quote from David Ash, who's a behavioral economist, sort of really captures the story. Education might work if there's a knowledge deficit. It's unlikely to work if there's a behavior deficit or a reasoning deficit. You might quibble with the choice of wording there, but I think the point of it is a valid point. And what I find is that I'm not denigrating education. I think education is critical, but it only can deal with certain aspects of the problem. And often it is not so much a lack of knowledge, but an issue with behaviors or reasoning, et cetera. And so David Ash sort of highlights this issue, and I'll highlight it again in a little bit. So that's the issue with education. What about behavioral interventions? I think they would be fantastic. They would really be incredible if we could come up with a behavioral intervention that essentially made people use condoms 100% of the time, or that did other things as well. But even when you think about the impact of behavioral interventions, mathematical models suggest that changes in behaviors in condom use, particularly short-term ones, and even long-term ones if they were only modest, would not impact syphilis rates. So it would take a lot for a behavioral intervention to work. I mean, you think about Thailand and the king saying you should use condoms, and everybody used condoms. Amazing, right? Amazing. But can you imagine if Donald Trump said we should all use condoms? It would probably not work as well. And so I think that's an issue. Now, the behavioral part of it also made me understand something, and this is something very frustrating often to clinicians, the behaviors. And I remember having a particularly bad day when I saw a patient, and this was his third episode of early syphilis in the past year. And the thing that I kept thinking is, what is wrong with him? Why isn't he just wear a condom? It's not that hard. What's wrong? Why these crazy behaviors? Why not be rational about it? And that same night, I actually went to dinner, and Linda Hellman, who's David Hellman's wife and a psychologist, looked at me with great concern and said, "You look terrible." And I told her, I was so upset, and I said, "I need a drink." And she said, "Listen," and this is what she said, which I found to be very zen. behaviors, no matter how irrational they appear to us, are always emotionally rational to the person committing them. Isn't that lovely? And then I found my Zen ever since then. And so every time I get frustrated, I think of what Linda Hellman said, and it makes me feel a lot better about that. But they are complex. Behaviors are complex. And trying to find one intervention that can be done in 5 minutes to change the sexual behaviors of somebody is really, really, really challenging. And so I'll leave it at that. Partner notification. You've heard about partner notification. And let me just read you this from Tom Peterman's article. I think, again, it's lovely. The number of patient interviews needed to identify one untreated partner increased from 2 in the 1950s to 4 to 5 in the 1990s and 10 in 2003. In some areas, the number of interviews needed to identify a new case has been as high as 25. Think about it. Interviews take manpower. And for the myriad reasons why it's becoming harder and harder to find partners, it takes a lot of manpower. And as the rates increase, you're having to essentially make hard decisions about who you're going to go after because the funding, the money, has not increased as well. And so you can't hire unlimited number of DIS to go out and find partners. So partner notification, while effective, is costly. And given the lack of money that's going into this, it can be very challenging to actually to do right. What about screening? Oh, it's lovely. I mean, screening is here. We have screening. It's not terribly complicated. And we have tons of mathematical models that have shown that frequent screening in high-risk individuals can lead to significant declines in the rates of syphilis. And so this was one study, this was several studies that showed that every 3-month screening among highly active MSM is very high yield and cost efficient. Annual screening of 62% of a population can lead to local syphilis elimination, but Q3-month screening of a high-risk group within that population, this goes back to Jackie Jennings's work, can lead to syphilis elimination. And so finding these individuals, knowing where they are, is it venue-based, is it individual behavior, et cetera, is it all of these things, can have a significant impact on the rates. So serological screening is lovely. And there are strategies that have been looked at to increase screening. Opt-out strategies have been looked at, and they seem to work. Automatic testing and linking screening to, for example, in HIV-infected patients, linking it to CD4 counts, HIV viral loads, et cetera, has been shown to increase it. Patient reminders. Dedicated staffing, of course, works very well. When you have somebody behind you saying, hey, screen. It works beautifully, but it's costly. And what's interesting here is that strategies that relied on provider education alone do the screening. Remember, it doesn't work as well as the other approaches. So somehow you have to find a way to automate this process to make it actually work. This is the sad story of screening right now, and this is from Alex Devu at the STD Prevention Conference last week. And she presented this, and this is syphilis screening among sexually active MSM who are receiving medical care for HIV in the US. And what you can see is this was based on their self-reported behaviors. And they looked at those individuals who were screened once a year in the past 6 months or in the past 3 months. And what they found was with anybody who said, I have had sex in the past 12 months, about 70% of those were screened. But then you look at higher risk behaviors and individuals who said, I've had condomless sex with greater than 2 partners. And you can see that the screening really hasn't increased that much. And those who were screened more frequently and more recently essentially was a small minority. So while screening is there, we're not really using it to its optimal possibility. And what's the problem? And look at this. And this is Kim Workowski. I know she's looking. Kim Workowski is the STD treatment guidelines, and she's sitting right here. And so I put this slide in because I knew she would be sitting in front of me, looking at me. And she reminds me that the STD treatment guidelines are not screening guidelines, and I totally agree with her. But the problem is people use these guidelines to get screening recommended. So they may not be at heart screening guidelines, but that's what people go to. People don't go to the USP-STF guidelines to go. So this is what it says. And you tell me, I'm a clinician, and I do STD research, and I'm confused by this. The following screening tests should be performed at least annually for sexually active MSM. And then they say the frequency of follow-up testing might be dictated by subsequent behavior. Screening is recommended annually at a minimum to include syphilis, When you read that, it's hard to know as a clinician how often you have to screen a person. It's hard to know. I mean, the take home for most clinicians when I ask them is, well, I have to screen them once a year, about once a year. But when you have that, what really happens is you wind up, if you're lucky, screening them once every 2 years, if you're diligent and good. This is not to even go with the PrEP guidelines, which were horrifying. When I read them, I screamed. There was a big primal scream that came out. So you have these high-risk individuals who are taking PrEP. Yes, they're taking PrEP, and they're being tested for HIV every 3 months. High risk, on PrEP, you have them. They're there, they're being tested for HIV every 3 months, and you say test them for syphilis and other STDs every 6 months? What were you thinking, right? It's crazy. So guidelines, in my opinion, are a low-hanging fruit. If we were able to be more prescriptive in our guidelines, if we were able to say, listen, if your patient is an MSM who's had condomless sex with more than 2 partners in the last 6 months, they should be screened every 3 months. Clinicians then would know what to do. Theoretically, you would even go with what Jackie has done, and venue-based recommendations. So if your MSM patient has met their partner on Grindr, you should be screening every 3 months. I mean, that's a nice way of taking what Jackie is doing and trying to implement it directly in guidelines that would actually be helpful. Now, there is a reason why guidelines are not as clear, as prescriptive. And it's highlighted in, again, the Tom Peterman, it's a great paper. It's a nice paper because he summarizes the thought and where we are with syphilis. So I recommend it highly. In areas with high rates of syphilis among MSM, routine annual screening should be encouraged in clinics that provide care for MSM. More frequent testing identifies more infections, Testing every 3 months increases the likelihood of finding infections before they progress to secondary syphilis, and thus should prevent more transmission than if the infections were found later. However, the actual impact on primary prevention is uncertain. And then he highlights a study that was done in Australia that I've referenced down there by Chow. And what they did was they increased screening from 48% to 91%, and they were able to find more cases of early syphilis, but a lot of those cases were early latent, and some of those cases were secondary. And so the question was, could you really decrease the risk of transmission by finding these early latent cases? Would it be enough? And then Tom says, without a randomized control group, it's unclear if the observed change in secondary syphilis was lower or higher than it would have been without increasing in screening. So in other words, what they're suggesting is, does screening really make a difference? And we don't have a randomized control trial to do it. And my argument is, at the end of the day, this is the only low-hanging fruit we have. And while we may not have great randomized trials to answer some of these questions, it would be very challenging to do a study like that. And it would take time, and the syphilis epidemic is still ongoing. And so sometimes, you don't want guidelines to mislead, but perhaps sometimes we can use less data to potentially make guidelines that may be more prescriptive and more helpful while things are happening. So this is just my opinion on things. So what are some novel biomedical interventions? We've talked about the parent approach. Can we enhance those approaches? So here's the vaccine. Lovely. And so, vaccines for syphilis, it's going to be another 20 years. I'm just going to start with a punchline. It's going to be another 20 years, but there is now momentum. And vaccines can be either therapeutic, so you give somebody the vaccine, it doesn't prevent them from getting syphilis, it just prevents them from progressing to more serious forms of syphilis, or they can be preventative. The last study that came out, major study, is a therapeutic antigen, potentially a therapeutic target that came out of Carolyn Cameron's lab. But it's still very early on, and there are no even there are no animal studies, let alone human studies. Now, the good thing is the NIH essentially said, okay, we're going to step in here. And what they've done this year is that for the CRC, so the CRC are these big grants that are given out every 5 years that support millions of dollars worth of research at about 4 or 5 centers around the country. And usually they're very broad, any STD, so you could do HPV, you could do the vaginal microbiome and not necessarily a sexually transmitted infection. But this year they said none of it. The renewal this year is actually vaccines only for gonorrhea, chlamydia, and syphilis. And by the end of those 5 years, they have to have a candidate vaccine that could go in for human trials. So the NIH became much more prescriptive this year on their CRC, and the NIH held a big syphilis summit vaccine not too long ago. And so there is action. But I can guarantee you, even with this action, it's not going to happen in the next 15 to 20 years. So vaccines are great. It's great that we're putting money into them, but not quite yet. And so this is the next big thing, and that is the use of doxycycline to prevent essentially infection with syphilis. And doxycycline has been used both as pre-exposure prophylaxis. So somebody takes doxycycline once a day, 100 milligrams, while they're high risk. So it's like HIV PrEP. So think about it, you're taking your HIV PrEP once a day, and you're taking your doxycycline with it. And there was one small study that was done. It was a randomized trial, very small, proof of principle study, that showed that, in fact, you could decrease the combined outcome of chlamydia, gonorrhea, and syphilis by about 70% if you were taking doxycycline once a day as compared to placebo. Of course, because the numbers were so small, they couldn't say for syphilis. But the point estimate for syphilis was actually 70% reduction as well. But it was not statistically significant. The numbers were very small. So that's pre-exposure prophylaxis, taking doxycycline every day. Then they did, as a subgroup, nested within the EPER-GAY study, they did a randomized trial within the EPER-GAY where they actually randomized individuals to placebo or doxy. And the way you do doxy, it's post-exposure prophylaxis. So you have unprotected sex, and then you're supposed to take 2 tablets of doxy within 72 hours after unprotected sex. So this is post-exposure prophylaxis with doxy, 2 tablets within 72 hours after the exposure. And what they found was that the hazard ratio for syphilis was essentially a decline in 70%, a reduction 70% in the risk of syphilis. For chlamydia, it was also that, but no benefit for GC. And so that's very interesting, because you could take high-risk individuals, give them doxycycline, a prescription for doxy, and tell them take it after you have sex, 2 tablets within 72 hours. Easy. Doxy is relatively cheap. And so what are some pros and cons of this? The pros, it seems to work. Granted, it's a small number. Relatively safe drug. We have data on doxy use in chronic acne, and people have used it for 5 years or more, and they don't drop dead. So, but the problem is when you go back to these studies and look at the measures of safety, they're looking mainly at essentially, do they have side effects like sunburn? They do. Esophagitis, ulcerations, intracranial hypertension, uncontrolled hypertension, these things. And the rates of those are very small. But there may be other things that they didn't measure at the time that may be relevant. But it seems to be relatively safe. You don't die if you take it. It's easy to administer. The problem is the other good thing is, well, the other bad good thing is that we don't have a lot of other options available. So it makes doxycycline look much rosier. And then in an unpublished study yet from Julie Dombrowski in Seattle, 80% or more of MSM in Seattle said they would be interested in taking doxy. The cons, we have very limited data. These studies were small. There were only about 23 cases of syphilis in the EPER-GAY study. So we're talking about very small numbers. The costs of doxy and beyond may be there. The side effects we've talked about, and most of these side effects, though, are not severe, and the side effects tend to be reversible when they happen. So if they happen, if you stop the medication, they tend to be reversible. But here's what we know. And then there's, of course, the issue of risk compensation, fine. But here's what we don't know much about. It's antibiotic resistance and the effects of doxy on the microbiome. And these are important things now that we worry about. And so this you've seen before, and I'm going to show you. This is not doxy, this is Clinda. They took 4 controls, 4 people who were perfectly healthy, and they gave them a week of clindamycin, an antibiotic. And clindamycin has activity against anaerobes, but most anaerobes in the gut are resistant to Clinda. It has absolutely no activity against gram-negatives, which are often found in the gut. So it's a fairly narrow spectrum agent for the gut. And what they found was this. So they had 4 controls, and then they had 4 patients who got a week of Clinda. Right before they got Clinda, let me see if I can do that. Look how beautifully diverse their gut microbiome was, right? This was right before they got Clinda. And they got a week of Clinda, and at the end of the week of Clinda, they essentially completely annihilated diversity. And remember, diversity in the gut microbiome is health, unlike in the vagina, where diversity is bacterial vaginosis. And so diversity in the gut microbiome is a healthy status. And so a week after that, you eliminated diversity completely. 3 weeks after that, you still had completely eliminated diversity in the microbiome. 6 months after that, you had, with that single 1-week course, you had eliminated the diversity. 24 months, 2 years after that, no intervening antibiotic use, you still had a microbiome that was significantly different than the microbiome that you had before the antibiotic. They've done similar studies looking at a single dose of Cipro and the effect on and you see the effect up to 4 years. And then when you look at the resistome, essentially when you take stool and you look at the presence of resistance mutations to the fluoroquinolones within the stool, it's still 400-fold higher than it was before the single tablet of Cipro was used 4 years earlier. And so the implications on the microbiome are not insignificant. Now you say this is Clinda, this is Cipro, but we have data on doxy, and this is a study that was done in mice. And you found the same thing. If they gave them doxy in mice, and you've looked at their microbiome, you're going to elicit dysbiosis. And dysbiosis in the gut means you're essentially taking away the diversity in the gut. And so that's concerning. But here's the real problem. We don't know what dysbiosis really means. So by decreasing diversity, there have been many things related to that. Obesity and diabetes and hypertension and so many things. I mean, whenever you look at any kind of outcome, any kind of disease outcome, you can link it back to the microbiome. What does it really mean, though? Right? What does it really mean? I took a sample down there, mice who had inflammatory bowel disease, and showed that in fact doxycycline and dysbiosis actually leads to better outcomes in those mice. And so the term dysbiosis, everybody's really excited about the microbiome. We do research on the microbiome. We're very excited about the microbiome. But we know nothing about the microbiome. And we know nothing about what the implications of dysbiosis means, of altering the microbiome. Yeah. And so a lot of people are saying, well, we should be doing studies with, doxy and measuring the microbiome. So you get a stool sample and you say, it's different. Of course it's going to be different. You don't even have to do the study. Don't waste your money. There's going to be dysbiosis. But what does it mean? What does this mean? And I think there's one study that might hint at that. So this was a study that was done. Now, mind you, this was a study. It was published not too long ago. And it looked at patients who had Q fever, Coxiella burnetii infection, endocarditis. And they get treated with doxycycline. And they get treated for at least 18 months, if not longer. But it's 100 twice a day of doxycycline, and they also use hydroxychloroquine treatment with it. So it's not just doxycycline, it's a higher dose of doxycycline. And they looked at those individuals, and what they found was that 23% of those treated patients showed abnormal weight gain, significant weight gain when they were on doxycycline and hydroxychloroquine. But then if you look at the actual figure on the left, you see that those who are on doxycycline, some lost weight, some gained a lot of weight, some, And so what does it do? And my argument is if you're going to do a study, if you're going to do a randomized trial looking at the impact of doxycycline, you're going to have to set it up not just to look at the microbiome and see dysbiosis. You're going to see it, I'm telling you now. But you're going to have to look at hard outcomes. And those hard outcomes may not happen in a year. They may take 2 or 3 years to develop. And so it's very challenging to do these big studies. So it's not an easy approach at all. But it certainly highlights that it's going to be impossible for us to make recommendations, broad recommendations about the use of doxycycline without knowing what this really means and how it impacts individuals. And this is not even talking about the emergence of drug resistance, and not just drug resistance to syphilis, but to chlamydia and other infections. And so, in summary, syphilis rates are increasing, particularly among MSM, but now among women and infants. The big problem here is that we don't have money. There's not enough money to do what we need to be doing. It's becoming more challenging to implement Thomas Parent's approach to STD control in the modern era. Serological screening is a critical component. Can we do better with guidelines? Can we mislead, perhaps, but actually help? I don't know. The vaccine is years, decades away. Doxycycline is here. It's exciting, but its immediate implementation is problematic. Remember, first, do no harm. Thank you.
Thanks so much, Khalil, and certainly an honorific award for engagement and keeping us all going. We now are going to turn to the panel session of the morning. I'll ask the panelists to come on stage, and I'm going to hand over the emceeing duties to Renata Arrington-Sanders, who is a member of our CFAR Adolescent and Young Adult Working Group, now an associate professor of pediatrics, and based at the Harriet Lane Clinic, and delightedly going to chair this session for us. So Renata, please.
Hi, we've had a wonderful morning, so I'm going to ask the panelists to come up. Dr. Andrea Wirtz, Dr. Joyce Jones, Dr. Lois Eldred, and Dr. Kimberly Workowski. So these are going to be some on-the-ground presentations, and just taking a time to maybe give some examples of clinic as well as research-based, and then we'll have an open discussion pulling some of the things that we've heard to get this morning together and how we apply it more broadly. I'm going to ask Dr. Joyce Jones to get us started.
It's hard to see.
Thank you, Renata, and to the organizers for inviting me to participate in the panel. So I am the Associate Medical Director of the Bartlett Specialty Practice, and I oversee our PrEP program as well. And basically I'll give you a brief overview of our practice and the clinician perspective of this syphilis epidemic. I'm going to focus on PrEP really, but obviously this affects our HIV positive patients as well. So our PrEP practice is located within our ambulatory infectious diseases clinic that's called the John G. Bartlett Specialty Practice. We provide HIV care, viral hepatitis, screening and treatment, general infectious diseases, transplant ID, and then PrEP as well. We have a case manager, patient navigator, and we have 11 providers who prescribe PrEP in our clinic. That's not their full-time job, none of us, and we have a nurse dedicated to PrEP. A lot of the work is done for our HIV-infected patients, but also for PrEP. And in calendar year 2017, we saw 51 individuals clinically for PrEP and prescribed PrEP for all of those individuals. We've engaged many more individuals than that with our outreach and other activities. So to give you sort of, this is Khalil gave me a nice segue in terms of guidelines. So as a clinician and as a clinic, we do look to guidelines to help us decide what we're going to do. So the updated guidelines suggest screening at baseline and every 6 months, and then every 3 months for people at increased risk for syphilis, including men who have sex with men, and then asking for symptoms for sexually active persons with signs or symptoms of HIV. And then to provide risk reduction counseling as well. But this is within a context, right? So Dr. Greenbaum did an excellent job of presenting the syphilis epidemic in Baltimore. We're living in an area with very high rates of syphilis, and we need to take that into account when we're seeing patients and running the clinic. And so what is our boots on the ground approach? So we should be really screening people every 3 months for syphilis. we need to, and what I definitely do, is incorporate our data into risk reduction counseling. So when I'm talking to patients, I tell them about the high rates of syphilis here to make it more palpable to them. Low threshold to empirically treat for syphilis, make sure we're collaborating with the health department for partner services. I have some good venue-based information I could share. And then looking to these potential other interventions. So computer-based, video-based counseling shows some promise. This question about PEP for bacterial STIs, point-of-care testing, other things that are being investigated that we may want to incorporate into our clinical practice.
Thank you, Dr. Jones. Okay, let me just pull up.
Where's mine? That one's mine. One below is mine,
Okay.
I think.
All right.
Yeah.
So, and just to give you a framework, these are sort of questions to think about. You heard the research and the science, but these are practical examples of how do we implement PrEP and think about syphilis. Now we're going to hear a little bit more about clinical practice. We'll hear some more larger national data, and then some work that's being done in an internet cohort.
Hello, I'm Lois, Eldred, and my role today is a PrEP provider. I think I might retitle this, "Give That Man Some Doxycycline," because I think it would help. Anyway, we were all asked to provide a slide or something like that, and I thought maybe putting some, kind of clinic-based stuff might be helpful. So this is a 61-year-old lovely gentleman that I started seeing about a year ago. He's a white man, he's gay. His first visit to Hopkins for PrEP was in August of 2017. He had already been on tenofovir FTC about 3 years at that point. He has a primary care provider he sees regularly. His past medical history, it's really significant only for migraines. He's taking sumatriptan. He has no other chronic medical conditions. In February of 2017, he was found to have an RPR of 1 to 16. He was living in Winchester, Virginia at that point. He went to the Winchester, Virginia Health Department. He was in the midst of moving to Baltimore, and so he came up here, and Winchester contacted the Baltimore City Health Department. His RPR was 1 to 4 pretreatment. He was treated as late latent with 3 weekly injections of penicillin. He did have a past history of gonorrhea and HSV. He said he did not have a past history of syphilis. So the first time I saw him, he had already been treated. He has described multiple male partners, and he thinks he is safe. Is this the? Is this one? There you go. Okay. So when I saw him, he had an RPR of 1 to 16 post-treatment, treated with benzathine pen-G 2.1 million units. In November, when I saw him, he was positive for rectal chlamydia and gonorrhea, treated with ceftriaxone 250 IM and azithromycin 1,000 milligrams PO. He came back, I saw him again in February, and he still had rectal chlamydia. I did a test of cure, treated him with azithromycin. We were sure to observe it. Talked with Charlotte and thought about possibility of LGV, but his test cure was negative. And his RPR was 1 to 16. In May 2018, he was CRFast 1 to 16. Here is somebody who has clearly having other STDs, treated as new infection with same injection of 1 treatment. And then he has continued to have new partners. He says he does not always use condoms, is how he describes it. About this point, I'm having a Khalil pre-Zen moment. and consistent comes back and basically has had an LP, which was negative. And I at one point called Matt Hamill and said, what do I do? And what do I do with this? And the possibilities are that he will remain serofast because 15 to 20% of persons do not have titers that go down. He could be getting to infection. I don't know that. It poses some interesting issues for us, I think. One is that what happens when we're a PrEP clinic and people are feeling safe because of HIV and don't feel the need to have protection for other reasons. And this is somebody who did not previously have syphilis. So that could be going on. What happens when you have a high prevalence in the community, which clearly we do. I guess I would pose it to the group as where do you go from here?
Thank you, Dr. Eldred. Okay, so we are going to move to Dr. Wirtz. I'm going to ask you to come up next just to talk a little bit about your internet-based study, and then we will hear more of the national data and pull it all together, I think. And then we'll open it up to a larger conversation.
Thank you. Good afternoon. So I am the one outlier in the group really focusing on the research piece, and actually going to talk about a different population today. So we've heard a lot about sort of the general population, we've heard about gay and bisexual men, and now I'm going to talk a little bit about transgender women in the US. So our study is called the American Cohort to Study HIV Acquisition Among Transgender Women in High-Risk Areas. It's a cohort that's currently enrolling. We're enrolling in Boston, New York City, Baltimore, Washington, D.C., Atlanta, and Miami. So you can see we're pretty much on the East Coast right now. Hopefully we'll continue to expand. And our goal with this study was really to fill in these research gaps in terms of HIV research on the specific HIV incidence and risk factors for incident infection among transgender women. We know that they are a high-risk group, but they're often brought into research under the umbrella of other populations, so often under the MSM categories. So our study just briefly we're aiming to enroll over 1,000 HIV uninfected transgender women in the US. We do allow all adults who identify along the transfeminine spectrum to enroll into our baseline, a cross-sectional study. So we do have women who are living with HIV at baseline come into that study at that point. Only those who are found to be uninfected at baseline then continue into the cohort. For the cohort, we're not fully an internet cohort. We have sort of a mixed cohort method. So we ask people to come in to the baseline, to our facilities for their baseline visit, where they do complete a survey, they complete HIV testing, and other STI testing as well. If they enroll into the cohort, they're followed every 3 months with study visits, and I say visits in quotations because they can either complete their study visit online through this app that we've developed, and they do a survey and home HIV self-testing, or they'll come into the facility. And we have about 18% of our sample currently have lower literacy levels, so all of those participants come in for facility-based visits. We then ask participants to come in again at the 12 and 24-month study visits as well. We do STI testing at baseline and every 12 months, and for syphilis and specifically, that's determined by a positive treponema and RPR. We do also baseline cross-sectional incidence testing to get a sense of what that incidence is in that first group that we see in the baseline survey. And so just to show you, this is in terms of the online piece, this is our app. You can see that participants can enter the survey through this top button here. We also provide them with a home HIV self-test kit. And so when they go to this link here, there's instructions on how to complete the test. We also provide instructions and demonstrate how to use it when they come into the baseline. But they can go there, there's a video link. They complete the test, and we ask them to report the results of their test, but they're also asked to upload a photo of the actual test itself so that we can log in and verify as well. So anyone who reports being positive or indeterminate, or if the photo itself looks to be indeterminate or positive, we then immediately contact them and ask them to come in. So to give you a very brief overview of our baseline results, as I mentioned, we have both HIV uninfected and infected participants coming in at the baseline study. So here you can see these are STI prevalence estimates. This is the total sample, so HIV infected and uninfected combined. We have about 16% prevalence of syphilis. Then when we look specifically at those who are living with HIV at baseline, there's about almost 33% prevalence of syphilis. And then that drops to 8% for those who are HIV uninfected. So I think similar themes to what we've heard earlier in this session. When we look specifically at correlates, I think there are certainly unsurprising correlates. So HIV infection, residence in a southern city, very similar to what Chris had remarked on earlier. Lifetime engagement in sex work, sex with a cisgender male partner in the last 12 months. But then there are a few other notable ones. So this one I find particularly important. We ask about barriers to care, and one of the most commonly reported barriers to care is this issue about safety when traveling to a provider. So I say this because, it's not just a perception. In our sample, 76% of women report some kind of lifetime form of physical violence. 46% report lifetime sexual violence. So it's actually a very real issue and concern for them. And so when we're saying, maybe they're not aware, or maybe it's just a behavioral issue that they're not going to seek testing or treatment, it's actually that some of them are weighing what are the benefits of risks of going or not going to the provider, but what are the benefits and risks of getting on the public bus or waiting on the street to catch public transportation to going to a provider. And so I really think that this kind of maybe relates back to Dina's earlier comment about these kind of blitz syphilis testing events and trying to meet people where they are so that you can really actively engage them in testing and treatment. The other one that I put up is this sort of correlation between full-time employment. So again, here we actually see an inverse relationship between employment status and their syphilis test result. And I think that's important as well, too, because if you think about people who don't work in a formal setting where they can have a paid sick day, how are they actually getting that time to go in and see a provider? So these are two important considerations that I think we often don't think about when we're kind of coming up with guidelines and recommendations. And the last one I threw in here was we also see this inverse relationship between sex with a cisgender female partner and the syphilis infection. I think that's not surprising in and of itself, but to say that transgender women do have female partners as well. And we often sort of make assumptions about the population of transgender women and their partnerships, and we're actually finding out that their partnerships and their networks are very different from what we typically assume. So some of the things to think about as we're thinking about those groups that are highest risk for both HIV and for other STIs. Thank you.
Thank you, Dr. Wirtz. That was very, very nice data to share. Thank you. Let's see.
Yeah.
This one? All right. Dr. Workowski, please. Thank you.
Thank you. So those of you that don't know me, I kind of play both sides of the street. I've been at Emory for 26 years, and CDC, I do some contracting work with them. So that's how I get involved with the kind of the guidelines process. And I could have a formal rebuttal to what Khalil had to say, but I think I'll stay on task. We'll do that with the discussion. So what I thought I would do is share with you just some data. The surveillance data is not really released yet, but I wanted to show you these sobering numbers. And we had mentioned before about the increases in terms of, this is just you see a little star behind the preliminary data, but this is kind of the real deal. So the numbers here are really sobering for all these STIs. Comparing from 2013 to 2017, I just thought it would be helpful. So this is not only a syphilis issue, this is also chlamydia and gonorrhea. This is looking at data going back to the 1940s, and this is again sobering. 385% increase in national data since 2001. If you look actually here at the graphs, you'll see that the rates, which is kind of interesting, the rates around men who have sex with men has kind of leveled off if you look, and there's only a 48% increase. But really what we're seeing is the increase again in heterosexual syphilis in terms of men who have sex with women, and what's really disturbing is the women. And even though the numbers are really small, this is incredibly disturbing. And then this is, we talked about this a little bit, but this is just very preliminary data, but you're going to see some more coming out in the next couple of weeks. But this is really disturbing. We tend to think of the IVDU epidemic as different, but really look here what's going on in women. And so this is really disturbing. I know in Atlanta, we're having an incredibly hard time with meth. So this is kind of really disturbing is what we're seeing. And it's what you're seeing in Baltimore, we're seeing a lot in Atlanta. And it's just ungodly what we're seeing in terms of the meth. You guys in Baltimore have seen a lot of IVDU. In Atlanta, we really haven't been a big hub until recently. And I'm just on hospital service now, and I just have somebody that was injecting oxycodone into their neck and has a big neck abscess. So it's coming, the endocarditis is coming, it's just rampant. This data was presented by Jeremy Gray at Croy earlier this year, and this is just looking on your left. This is primary and secondary syphilis among MSM with HIV infection, and then on your right without HIV infection. You see they're pretty similar. So again, not only are we're seeing in kind of the same risk groups in terms of Georgia's way up there. So, you know, just like you guys in Maryland, we're having an incredibly big problem. Congenital syphilis was mentioned. And again, I just want to highlight and just put together what kind of you guys have been saying all morning. There's two epidemics in the United States, heterosexual and MSM. And so we have to think about the different messages and prevention tools. So I just want to show you the graphs that's going up. You mentioned before about how much you're seeing in Maryland. These are the top 10. And Georgia's right up there with you guys. California is having a really big problem, and Ohio is really, you're scratching your head like, why Ohio? And all the reasons are very different in the different locations, but Ohio, a lot of it has to do with the drug epidemic that's happening there with Ohio. But again, it's really interesting what's happening with these rates and very disturbing. So in terms of the epi, that's a little bit of the epi and putting it together on the national viewpoint. The other thing I really wanted to mention was what are we doing with treatment? And Khalil really nicely, elegantly talked about what we're seeing with the issue, pros and cons of using doxy. And you know, there's been a lot of reticence, especially in HIV clinic situations, that more is better. And my patient with primary syphilis, they really should get 3 shots just because their T cell is 200 or 30. Not based on data, but just because. And so the current recommendations are just a single shot of benzathine for primary, secondary, early, latent, just to remind everybody. And we have several studies, most of them observational or an older study that some of the participants in this audience participated in, the Bob Rolfe study in 1997. But the bottom line is that what we have from that study and the observational data, there's really no difference in outcomes, 1 versus 3. The STI CTG is doing a study, an RCT, looking at 1 versus 3 in HIV uninfected, as well as HIV infected, to try to definitively answer this question. And then I'm not going to go over the Molina data, which you so eloquently went over, Khalil. But my own kind of other point about that is the really big concern with antimicrobial resistance, especially in GC. Because 30% of GC nationwide is tetracycline resistant. So, you know, people, it was one thing to get 2 pills after you have sex, but if you've got 10 sex partners a month, that's a lot of doxy. Just saying. And then this is, some of you, I think, Khalil and Jonathan and Ann and Charlotte, I think were at this meeting by the CDC a couple of years ago, and really stressed the importance of the 2 epidemics in heterosexuals. And basically, you need to think about it differently, different approaches for different reasons. We have had some historical success, especially associated with transactional sex. when the rates were extremely high in the 90s, but that really took intensive partner services, contract tracing, and we really don't have the manpower to really do that. And there's less success in large MSM epidemics, and so we really need new approaches. So I'm really excited about the network use that you guys are doing. But one of the things that I think is missing, in particular in my experience in my HIV clinic, is mental health services. So a lot of these people that I talk to that are what I call STD frequent flyers, basically, they're depressed. They want 5 to 10 minutes of some kind of togetherness. And the mental health services are sorely a huge problem. And the other issue is the silo between the funding streams between HIV and STD, and coming together and saying we're towards a common theme instead of having this siloed presentation. That's my soapbox. Then in terms of, from my clinician standpoint, the varied clinical presentations that the house staff are missing because they don't know syphilis. You can pick up spots. I mean, that's easy. I was showing Khalil some great patients I've had, very interesting, in my clinic with oropharyngeal presentations of secondary syphilis. They came in with a sore throat. They had no other manifestations, and it was syphilis. I've seen in the past 6 months, I've seen 3 tertiary syphilis with cardiovascular manifestations. The ocular presentations, which you guys are aware of, but again, it's varied presentations. And in particular, just a little anecdote, I was just asked to see a patient that had been out of HIV care. And he's holding his head like this, and the lights are out, and I said, what's wrong? I have a horrible headache, and he says, they think that I'm drug seeking. And they did an LP, and the LP was normal. And I said, well, why are the lights out? He goes, well, because they're hurting my eyes. He had ocular syphilis, and they didn't put, the LP was normal so that he couldn't have ocular syphilis. So again, even though you said education really is not going to be our total answer, I still think we need to do a better job of showing these varied presentations and keeping it on our kind of radar screen. And then this is just a number of things that came out of the presentation, and for the sake of time, I'm not going to go over them, but it's just the issues that were identified in terms of our laboratory diagnosis. We need better tests. These tests are not quick enough. They're not sensitive, especially in primary syphilis. They're not point of care. So we talked about the vaccine development. There has to be differences between the heterosexual and MSM kind of discussion. And in particular, what really hasn't been talked about well is this issue with bridging. So people that go between the 2 networks, that go back and forth, we don't have good data on that. And so that's really important, and that really what needs to be looked at in the heterosexual kind of part of things. And so there's different things in how we should prioritize in terms of our prevention strategy depending on what your epidemic is. And then I would again say we need to link mental health, we need to, our substance abuse issues, and they all need to come together instead of having this funding here and this funding here and nothing combined. So that's my soapbox.
Thank you for a wonderful presentation. So I'll start asking the first question to the panel. I'm really interested in, I think, Dr. Wirtz, you presented some very interesting data, large cohort across 6 cities where people are having real barriers to getting into care. And they're not able to come in. They have high prevalence of syphilis at baseline, up to 30% you showed in your data. And right now the guidelines suggest the early screening. How do we change this? Lois, you talked about different individuals that might not necessarily really be aware of syphilis or think that they're at risk. How do we change this? How do we get people in to get tested, get them the treatment, and also get them the education they need to understand the importance of treatment? I'm thinking about my own patient that I had a long conversation with yesterday, a 30-year-old man that now has increased titers after having neural syphilis, and he says, "But doc, I've been treated. Shouldn't this be done?" So how do you do all that?
Thank you. I don't know that I have all the answers for all of that, but I do think there are a couple of things to consider. For the highest risk people who we know that we can reach in the field, I think I would go back to Adina's method of sort of these syphilis blitzes and really taking out mobile clinics as has been happening, going to places where people are and making sure that we can provide that testing and the treatment on site. I think that sort of addresses some of those transportation issues and the issues of expecting people to be able to come into a clinic in a 9 to 5 period, which is kind of the normal practice. I think that there has been discussion of coupling the HIV testing with syphilis, and as we really focus on targeted testing and treatment for transgender women, that's certainly an avenue that coupling is appropriate. If they're coming in for HIV testing, it should be standardized protocol to provide that syphilis testing and treatment as well, and appropriate referrals. We are, with our online cohort, we're investigating ways in which we can use the online venues as a method and online approaches as a method to reach people. I think, in emerging technology, it's very easy for us to kind of slap an app and slap, point of care self-testing on things, but that really needs to have a very thoughtful approach as well. So I mentioned earlier, 18% of our sample has low literacy levels. So if we're thinking about online approaches, self-testing, we also need to think about what about the groups who don't have apps? What about the groups who have lower literacies? And there are a lot of other pieces that need to go into that. So I don't think there's one appropriate answer, but I think that there are multiple approaches for these very different characteristics within the high-risk populations. Yeah.
Do others want to respond to that question on the panel or have thoughts?
So the other thing I think is just really defining what your epidemic is. So as you clearly defined what's happening with your young white women, that's quite of a different response in terms of that you're going to do versus the MSM that's had syphilis for 16 times, one of my patients. So that's a quite different approach. And so the issue in terms of your interventions and what you're seeing, that's where the epi drives the prevention, right, in terms of what's going on in Baltimore. I can speak from my own individual practice in terms of the HIV clinic. As we're seeing patients that are in routine care less frequently, they have electronic orders that they come in, do self-testing every 3 months. And I have them come and do their RPRs, so they don't even have to see me. I just make orders and they come in and do the testing. And then clarifying a little bit, I have to say this, Khalil, about what you mentioned, was that the issue that's been so challenging in terms of those guidelines and where, in terms of the frequency of the testing, there is, which you left out on your slide, is that more frequent is talking to the patients. And so instead of putting a Q3 or Q6 months on everybody's head, it's basically determining that on risk. In terms of, I know it doesn't happen for one, but I know in my practice, that's what I do, depending on risk. The doctors, though, in terms of the HIV clinic, they're concerned about their ARVs and doing their check boxes for everything else, and they're forgetting to do this or asking the questions. And even if they have unprotected sex, are they even looking at their bottoms? Yes. Because they've only got 15 minutes, and that's a lot to do. You got to put your stuff in Emory, and if they've had unprotected anal sex, are they even doing it? Are they doing bottom exams? So,
yeah, I agree. In the HIV clinic, I think we have a hard enough time making sure everybody's asking the right questions. And then you talk about general internal medicine, right, where these HIV negative folks are coming in and never being asked anything about risk, never getting a syphilis test. So I think I agree, provider education behavior change among providers is very difficult, but something that needs to be addressed one way or another. And having the patients have more control over that, right? So they have the ability to answer the questions on the tablet. They can do self-swab, etc. I think could be a helpful way to address this this gap in identifying risk and getting the right testing done.
I also think in terms of time-consuming but necessary, it's looking up items, but it's also anal paps, which is really if you have 15 minutes, it's a real time consumer. But our population is very high risk for anal dysplasia, and it's something that we're not getting often enough.
So I think the other problem with, just to show you some of this disconnect, the issue between, for the PrEP guidelines, which initially when they came out, I was totally against that Q6 screening, and some of the difficulties with getting behemoth guidelines through, let's say, political morass in terms of things, and having different people with their hands and fingers on things. Trying to do that in a way that meets everybody's needs. And so I think that the issue is, the way it is now, especially in the MSM section, is that you as a provider determine that frequency of screening. It should be done at least once yearly, but more frequently depending on what you think and your risk. And there has to be a talk and a dialogue between the provider and the patient. It's easy to do syphilis screening. You don't even have to ask anything. You just click a box. But the extragenital testing, that's more involved in terms of asking and swabbing.
Mm-hmm. Especially when there's some other barriers to care, disclosure of your sexual orientation, et cetera. Mm-hmm. So we're going to open it up to questions.
So I have a
Yes.
Okay. I have a comment and a question. One is, I want to emphasize Kim's point about the mental health issues. Actually, Emily Erbelding in the early 2000s did a full psychiatric assessment of patients with STIs in the STD clinic. And what you find is actually it's not just depression, but it's also access to disorders. And I think one of the key issues is understanding what some of the underlying issues here, because that will drive interventions. Because right now, we're just peeing in the ocean sometimes in terms of this. So I think that's just something that's not. The question is this: I think if you look at what you're describing is various fragmented interventions in different groups, and if you look at the universe of things that have worked in terms of things like chlamydia screening, mammography screening, pap screening, but these are situated, or even in the inpatient side with the patient safety movement towards bundles. And I think, how would you conceptualize, standardize, and it's not going to be, because I think you've all said that provider education and leaving too much discretion on the provider presents problems. So how would you conceptualize a bundle or standard guideline for individuals, which then could be measurable? And as health systems move towards, and I think one of our challenges is health systems move towards more population-based health, if they really ever get there, this should be part of that. But how would you guys conceptualize these?
Great.
I can, so my stab, that the most difficult thing I think is defining somebody at high risk. So I was just reading on the plane coming up here, I was just reading the new guidelines that came out for syphilis screening in pregnancy. I don't know if you guys saw that. So it just came out in JAMA 2 days ago. And so the big issue it comes to your question, I'm getting there. So it comes to your question about frequency of screening and who do you define as high risk? So we know that when a pregnant woman, when somebody is pregnant, they come in, you're going to screen at the first time they come in to see you. So what the recommendations say in the guidelines is to repeat screening at 28 weeks and then at delivery, if at high risk. So I think that's the main question, is the people that are not, because people ask me all that time, what are the recommendations for screening for syphilis? I said, we really have MSM screening recommendations, we have HIV, and we have corrections. What else do we have? what are the defined risk factors that we have in the heterosexual community? We don't. And so I was actually looking at the references that the U.S. Public Service Task Force uses, and it's all over the place. So your point is very well taken, except that I don't have, how do I find what's at high risk? They use an area of high prevalence. They use HIV infected. And then if you look at the other syphilis guidelines from the U.S. Public Service, it's black men under the age of 29 for in terms of what their recommendation is. So does everybody feel comfortable with that, and how do you bundle it? Plus, the other thing is not all STDs.
The irony is when I was an intern, we used to, every medical admission got an RPR. That's right. She doesn't know how to shut off her phone.
Another question?
But in terms of the bundle, is there...
Any other thoughts?
Well, the other thing I know that what we're trying to do internationally, this is more for pregnant women. There is a bundle in terms of pregnant women with Group B strep and syphilis and HIV. The difficulty is just the difference in the epidemiology and how do you define high risk. It's a great question. I don't know how to answer it.
Any other questions? Didn't I just take this one?
Well, I want to thank everybody. Very engaging, really. I guess the question I have relates a little bit, Andrea, to what you presented, but maybe also for you, which is just that I think when we look at the CDC surveillance and also we look at the guidelines, there really isn't any articulation of transgender populations. And I think even the early preliminary data that you're showing from the first, 150 or so of your trans women is that this is a very high-risk subset. And, how are we handling that? So when you see a curve that has men, women, and men who have sex with men, transgender women are either nowhere or they're under men who have sex with men, or maybe they're in with women and people just haven't made a cis or trans distinction. And, what is I guess the question really is what is the likelihood that we're going to see some refinement of that? Because it clearly is not capturing, it's inadequate to describe the various categories when we are, as we are, moving beyond the gender binary.
You want to comment? I can say something.
Yeah, and I can't say specifically for national reporting, but I do believe that there is much more recognition of transgender populations and transgender women specifically in terms of HIV and STI risk. And so I think that if not in the near future, it will eventually move in that direction where they would start to be identified in some of these surveillance techniques, but I don't know the exact when that would actually happen.
That I can't answer in terms of when that's going to happen for surveillance purposes, but there is a section on transgender in the STD treatment guidelines. So I'm not sure, I don't know if you're aware of that, but there is a section there. The issue is it's a behemoth process, as those that have been involved with guidelines formulation, and we don't have a process or the manpower to make this online as other DHS guidelines, where it's online like with the antiretrovirals and the OI. We don't have a process that to do it every 6 months. We just don't have the funding to do it. And truthfully, the field doesn't move as quickly as terms of the HIV with changes in new drugs and things like that.
Yeah, I was really sort of following up on your comment, which I thought was absolutely terrific, about how the epidemiology really needs to drive the prevention approaches. And if the epidemiology is not capturing the populations, then,
yes.
then we're in trouble.
I mean, our own electronic medical record, we're not able to formally identify individuals who are transgender. So, we have, yes, systematic limitations.
So an important step going forward. We now are at the end of this part of the morning session. We're going to move on to the bridging keynote from Patrick Sullivan. Just before we do that, please join me in thanking the panelists.